Ma'am, thank you so much for that introduction, and good morning to everybody. And this is a sponsored session, so the slides are sponsored and given by Dr. Reddy's. So I'm supposed to present a decade of real-world experience of rituximab, and there are, obviously, numerous publications. As ma'am said, this drug has been available in this country for a long time, and it really has helped in widening the access of chemoimmunotherapy to a lot of patients who didn't have access to it because of the cost of the originator molecule. But the worry in the clinicians and the patient's mind always remains whether this drug is equally as effective as the originator molecule. And to address that, there were several studies done, and we'll discuss four of the key ones. The first one is a retrospective analysis from a tertiary care hospital in Mumbai. The second demonstrated safety profile of the new molecule, the generic one, which is Reditux. And the third publication is the largest biosimilar real-world evidence from across India, and 29 centers and more than 2,000 patients were enrolled. And finally, we did a meta-analysis recently. It's unpublished at the moment, and it's about biosimilar rituximab versus the originator molecule, which is Reditux now. So originally, the originator molecule was known as MabThera, and the first study was done from Tata Memorial, and it's a comparison of efficacy and safety of rituximab, the MabThera, the original molecule, and its biosimilar variant in DLBCLs for the patients who were treated with chemoimmunotherapy. And this was a retrospective analysis, observational study, and pharmacy records were obtained for all patients who had taken treatment with rituximab. So patients were grouped in patients who got only MabThera, patients who only got Reditux, and the third group where patients received both brands, or even the brand was unknown. And the primary outcome really was to compare progression-free survival in patients who were receiving CHOP with Reditux or versus MabThera. There's several secondary outcomes, and the response rates and overall survival in the two groups were compared, as well as side effects. So the patient characteristics showed that MabThera and Reditux baseline characteristics was roughly equal. If you look at the Kaplan-Meier survival of progression-free survival on the left, it's rituximab in general, which is about 67% progression-free survival. Median survival not reached. And on the right is the comparison, which I must point out looks slightly better for Reditux, but it's not statistically significant. So the p-value on the right is 0.5, which means it's not significant. Um, and these are the response rates, including CRs, PRs, progressive diseases, and the status after CR and progressive disease. So overall survival, overall with rituximab was at 5 years was 84%. The graph on the curves on the right show Reditux with red and MabThera with blue. Again, statistically not significant, although it slightly looks better for Reditux. So 5-year progression-free survival and overall survival for all patients who received more than 4 cycles of either brand. Um, Roughly overlapping curves, overall survival, again, statistically not significant. What is significant is the 5-year overall survival by disease stage, which we all know, obviously, stage ones are going to do better than stage twos and so on and so forth. Stage four is doing the worst. And the International Prognostic Index, indicating that the patients with a very good IPI would do much better than good or poor. And if you look at this, median progression-free survival, median overall survival with the poor IPIs is really bad. So that's where the area of need is. And so the toxicity profile, fortunately, not a very toxic drug, and comparable toxicity between the originator drug and the generic one. So in conclusion, this study said the response rate, sorry, progression-free survival and overall survival in the two groups was similar to the results demonstrated in various randomized trials, which have only looked at the originator rituximab. It was as efficacious as MabThera. Obviously, the cost advantage makes it a much more attractive option for us in this country. And although there was slight trend to improvement, it wasn't statistically significant. It was a retrospective study, so should be interpreted with caution. Now, the other one, the second one I was going to present was this study which was published in Indian Journal of Hematology in 2018, and it looked at only infusion-related hypersensitivity reactions, so IRHRs with biosimilar uh, monoclonal antibody versus uh, the originator in Indian patients. So this was again retrospective, and it was a chart review in all patients who with B-cell lymphoid malignancies who were treated with rituximab-based regimens were included. Um, and any patient who received at least one dose of Reditux was included, and the infusion-related hypersensitivity reactions, according to CTC version 3 criteria, were allotted to patients. So, as expected, the common ones being DLBCL, follicular lymphomas, and CLL, and there's several uncommon or rare ones, and I won't name all of them. These are the variables. So, if you try to predict what variables would lead to a higher infusion-related reactions, it's not possible, and none of these parameters was found to be significantly associated with a higher rate of infusion reactions. Now, infusion reactions, this is a current study and published literature on the right. And some of the infusion or some of the criteria not reported in some studies. But if you look at grade 2 and grade 3, it's fairly comparable to the original molecule. So at the end of treatment, the CR rates were 62%. In patients with infusion reactions as opposed to 16 without. So it doesn't matter whether you get a reaction or not. And all it says is use of biosimilar rituximab in with B-cell NHL in Indian patients was not associated with a higher grade 3 or 4 infusion-related hypersensitivity reactions. So that gives us reassurance that it's a fairly safe drug, and the infusion-related reactions are roughly equal to what we expect in the on the originator molecule. So the third study is real world outcomes of diffuse large B-cell lymphomas in the biosimilar era. And this was a big one. And this in this data was collected during routine clinical visits, and the baseline data was measured for each patient and was compared to data every 6 months. There were several endpoints. So primary endpoint was the 2-year progression-free survival, with several secondary endpoints, including overall response rates, CRs, PRs, and two-year overall survival. And of course, adverse drug reactions data thrown in. So, 29 centers across India over a 7-year time period participated, and effectiveness and safety was assessed for up to 2 years after the first dose. So, almost 1,370 patients were enrolled, and as expected, out of those, 1,250 were Reditux. So, because it was giving such a huge cost advantage, a lot of physicians and patients decided to use Reditux instead of Ristova, where only a minority were included. And this really signifies the confidence that people get using the generic version, saying that we can really be confident that it's a equivalent product. So demographics are roughly equivalent within the two groups. If you look at ABC, GCB, the stage of the disease, if they've got extranodal disease, what kind of performance status patients have, comorbidity scores, and the quality of life indicators, all roughly equal between the two. Summary of chemotherapy treatments at baseline. So it's just trying to say that CHOPR versus CHOPR-like therapies were the commonest treatments. Some of them got rituximab monotherapy, but mostly it was the large majority was R-CHOP-based treatment. So if you look at progression-free survival at 2 years, Kaplan-Meier curves here, and the progression-free survival curves really overlap with each other, suggesting a comparable progression-free survival in both cohorts. So Reditux here is in blue and Ristova is in red. So you can see both the curves are really overlapping. Similarly, with overall survival curves at 2 years, both curves overlapping, suggesting a comparable overall survival in both cohorts. So it didn't matter whether you use the original or the generic version. These are other efficacy outcomes. So whether it's DLBCL, or best response rates or event-free survival, they're roughly equivalent. If you look at the right column, the p-values are not significant for any of them, indicating both groups perform equally well. So these are the patient-reported problems or quality of life indices, and Reditux on the left and Stovo on the right. Baseline bar charts are baseline on the left and at 2 years on the right. So there is improvement, obviously, with mobility and usual activities that they perform, self-care, pain, anxiety. But the thing to note here is that improvement is equal between the two groups, indicating that both the groups are doing equally well. So, safety outcomes, if you look at adverse reaction by severity, fortunately, the grade 3, grade 4 adverse reactions are not very common in both groups, but even the common ones are roughly equal, indicating that both drugs are safe enough. So, this is 35% of patients who could afford rituximab in 2010 because the original molecule was so expensive. And 10 years later, rituximab is given to more than 95% of DLBCL patients. So that really improves access of chemoimmunotherapy to our patients, especially in this country where cost can be such a major factor, where uninsured patients then don't end up getting a treatment at all if there's no generic variable available. So, in our healthcare system, it has helped in providing a cost-effective treatment and an alternative to the original drug. So it's also powered by real-world evidence at various time points. We see various evidence indicating equivalence. So why not do a meta-analysis to integrate all these evidences into one simple area? And this is what we did recently. It's a systematic review and meta-analysis of therapeutic equivalence of biosimilar versus the original rituximab. And the method was is the study only included or the meta-analysis only included studies which had done a head-to-head trial comparison between the Reditux and the innovator rituximab. And it didn't matter what was the sample size as long as the study fulfilled the criteria and both molecules were compared, it was included. So we looked at various databases and identified 72 studies, out of which five studies met the inclusion criteria. Four were real-world evidence studies, and one was a randomized control trial. So if you looked at the pooled analysis of all these studies, more than 2,000 patients satisfied the requirements for inclusion, and these were the ones we analyzed. So these are the designs and characteristics of studies included. Obviously, there is a lot of heterogeneity, but if you look at the characteristics of the patients, we can then pool all these patients together. And these are the results of the studies, progression-free survival, overall response rates, what kind of febrile neutropenias they get, and what kind of diarrhea-related side effects. So for those of you who are familiar with forest plots, this is going to be easy, but the central vertical line is the null hypothesis, and the horizontal lines indicate values from each study. If the central line is being crossed by the horizontal lines, that means that there is no difference between the comparator products, and the little diamonds at the bottom showed pooled analysis. So if you look at the entire data on progression-free survival, there is consistency that most of these lines are crossing the midline, indicating that although there is heterogeneity among studies, there was no significant difference in progression-free survival, whether you use the generic rituximab or the innovative one. Similarly, with the overall survival, most of the diamonds and most of the lines, in fact, all of the lines here, especially the pooled analysis, is crossing the midline. And here the heterogeneity was slightly low, but there was no statistical difference between overall survival between the generic and the originator one. So overall response rates, I mean, the wider the line, the less confidence in the study. So the smaller studies would have wide lines. But if you look at the pooled analysis, then it doesn't favor either the innovator or the generic version, which means both are roughly equivalent. So this is the summary of overall response rates, complete response rates, partial responses, progression-free survivals, and overall survivals, and includes febrile neutropenias amongst all the studies and demonstrates equivalence. So in conclusion, this systematic review and meta-analysis demonstrates that the biosimilar over the last many years has been shown to be as effective and tolerable as the innovator molecule. And obviously, it's a cost-effective alternative. And in a country like us, it gives us a big option to treat our patients without cost to be considered. So that's all I have. Thank you very much for listening. And if there are any questions, I'll be happy to take them.
Thank you, Dr. Nitin Sood, for that wonderful lecture. Sorry, I joined late because there was some confusion in the timings. I listened to your lecture. That was great and fantastic.
Thank you.
Um, let me start our webinar because I did not introduce any of them. So I'll just share the screen and then I will just take a question answer session from you. So just hang on with us. Thank you so much. Can you please unshare your screen first?
Oh, sorry, yeah. I don't think my screen is sharing.
If you can unshare.
Right. Oh, right, hang on. Yeah, got it.
Thank you. So first of all, I apologize for the late joining because there was some miscommunication. Well, very good morning to all of you, and good afternoon, good evening to all others who are joining from rest part of the world. As we heard, we have two guest speakers, and the first lecture is already over by Dr. Nitin Sood from Gurugram, and we have a second guest speaker joining us, that is Professor Dr. Neha Kamble from Pune. We heard our guest speaker, Dr. Nitin Sood from Gurugram, and he gave a wonderful lecture on a decade of real-world experience of Reditux. Our second guest speaker is Professor Dr. Neha Kamble from Pune, and she's going to lecture us on diagnostic conundrums in myelodysplastic neoplasms and newer modalities of testing. This webinar is, as usual, brought to you by Mumbai Hematology Group, supported by Dr. Reddy's and managed by Perfect Square. I thank Mr. Ashok, Mr. Tarun Pratap Singh, and from team Dr. Reddy's, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Jyoti Kotwal from Delhi, our guest speakers, especially a very special thank to Dr. Nitin Sood from Gurugram and Professor Dr. Neha Kamble from Pune. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're locked in. Let me give a flavor of our next weekend activities. Next Saturday, that is 4th of January 2025, from 7 p.m. US Eastern Time, 7 p.m. Indian Standard Time, and 8:30 a.m. US Eastern Time. We have Dr. Lashmi Nayak from Boston, USA, speaking to us on primary CNS lymphoma from A to Z. And the following day, that is Sunday, 5th of January 2025, from 11:30 a.m. Indian Standard Time and 6 a.m. UK time, we have Dr. Paula Palton Meggs from UK, Manchester, speaking to us on prevention and treatment of infections in the absence of spleen. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Akshay Mandloy from Agilus Diagnostic Mumbai Reference Lab, Mumbai. Dr. Amrit Kaur Keller from Kokilaben Dhirubhai Ambani Hospital, Mumbai. Dr. Amrita Saraf from Sar Gangaram Hospital, Delhi. Dr. Anju Bharti from Banaras Hindu University, Varanasi. Dr. Ankur Ahuja from AFMC, Pune. Dr. Deepak MB from MSMC Narayan Health City, Bangalore. Dr. Durga Devi S from Manipal Hospital, Bangalore. Dr. Hormaz Diyar Soli Sadri from Navsari. Dr. Jyoti Sauni from Gujarat Cancer and Research Institute, Ahmedabad. Dr. K. Gayatri from Lifeline Tapadia Diagnostic Center, Hyderabad. Dr. Kunal Goyal from Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. Dr. Meenakshi Suri from Jammu. Dr. Mohammad Taha Ali Khan from Medicover Hospital, Hyderabad. Dr. Myat Malle Sway from Myanmar. Dr. Omshri A. Shetty from Tata Memorial Hospital, Parel, Mumbai. Dr. Parimal Sarda from Hemato-Oncology Clinic, Vedanta, Ahmedabad. Dr. Pratik Bhatia from PGI, Chandigarh. Dr. Ramesh Balasubramanian from Velamal Medical College and Hospital, Madurai. Colonel Dr. S. Venkatesan from Armed Force Medical College, Pune. Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida. Dr. Shivani Joshi from Nashik Hematology Services and Mumbai Onco Care Center, Nashik. Dr. Shrutika Java from Jaslok Hospital, Mumbai. Dr. Shubhangi Agale from Grant Medical College, Mumbai. Dr. Shweta Rajpal from Actract, Mumbai. Dr. Udyan Khachi from Vadodara. Dr. Vidisha Mahajan from PD Hinduja Hospital and Medical Research Center, Mumbai. Dr. Vijay Tilak from Varanasi. Dr. Yi Montan from North Okalapa General and Teaching Hospital, Yangon, Myanmar. Just to introduce again our guest speaker who just spoke to you very nicely, wonderful lecture by Dr. Nitin Sood. He is Senior Director, Clinical Hematology and Stem Cell Transplant at Medanta Medicity, Gurugram. And just to introduce him briefly, whom you learned today and whom you listened from him, he is a clinical hematologist with over 20 years of experience. And he was awarded a bursary in 2011 by UK Myeloma Forum, American Society of Hematology, and first prize by British Society of Hematology way back in 2009. Dr. Nitin Sood is a member of the General Medicine Council, UK, Royal College of Physicians, London, Royal College of Physicians, Edinburgh, Royal College of Pathologists, UK, and membership of Royal College of Surgeons. He completed his MBBS from Government Medical College and then followed by MD General Medicine from Delhi University, DNB General Medicine from National Board of Examination, and FRC Pathology from Royal College of Pathologists. His clinical interests include hemato-oncology, hematology, hemostasis and thrombosis, etc. He earned his FRCP 2008 Royal College of Pathologists UK, MRCP in 2005 Royal College of Physicians UK, MD in 2002 Delhi University, DNB 2002 National Board of Examination, and MBBS 1996 Mysore University. And wonderful lecture he gave today that was on a decade of real-world experience of Reditux. Coming to our second guest speaker for the day, we have Professor Dr. Neha Kamble from Pune. And just to briefly introduce Dr. Neha Kamble, she is MD FIDH, Unit in Charge and Assistant Professor at Department of Pathology at Dr. D.Y. Patil Medical College, Hospital and Research Center, Pune. Dr. Neha Kamble is a consultant hematopathologist with expertise in hematological malignancies, and her major area of collaborative work is being done in Europe. In India, she is working as the unit in charge and assistant professor, Department of Pathology at Dr. D.Y. Patil Medical College Hospital and Research Center, Pune. She is working as a research team member in Stem Cell Unit, Sanakin Scientific Biotech, Germany. Her major areas of expertise are hematological malignancies, optical genome mapping, bone marrow microenvironment studies, CAR T-cell immunotherapy research, and biobanking. She did a fellowship in diagnostic hematology, followed by specialization in experimental hematology from Barcelona, Spain. She's also trained in flow cytometry from Josep Carreras Leukemia Research Institute, Barcelona, Spain, and in immunotherapy and CAR T-cell unit from Hospital Clinic, Barcelona, Spain. She has an integral role in setting up meniscal tissue biobank for the novel meniscal transplant project in India in collaboration with Quirón Hospital, Barcelona, Spain. She is the founding director of Sciences Global Healthcare Private Limited India, through which she helps place hematologists in Asia Pacific and neighboring countries for fellowship opportunities in Europe in various subspecialties of hematology through academic collaborations with university hospitals. She is the president of the Medicare Charitable Trust Foundation, which primarily focuses and works on medical, academic, research, and social fronts, and is actively involved in philanthropic activities. She is a member and has affiliations with the following hematology association and work closely on various boards. She is having various board membership, sounding board member for guidelines formulation for NHS hospitals, British Society for Hematology BSH UK, British Society of Hematology BSH London, Royal College of Pathologists RCPath London, European Association of Hematology EHA Netherlands, European Association of Hematopathologists, that is EAHP Netherlands. And today she is going to lecture us on diagnostic conundrums in myelodysplastic neoplasms and newer modalities of testing. But before we get to, let me introduce our special guest and chief guest for the day. We have with us Dr. Jyoti Kotwal from Delhi. Dr. Jyoti Kotwal is chairperson and professor at Department of Hematology, Sir Gangaram Hospital and Kripma, New Delhi. And it's my privilege again, ma'am, to invite you as our chief guest for the day to inaugurate our webinar and give some words of wisdom. I stop over here. Thank you so much. Over to you, ma'am, for
Yeah,
your.
thank you. Thanks. And because of the timing issue, I, in fact, introduced Dr. Nitin Sood. I just opened my laptop, saw the uh, uh, whole thing, and I introduced him. It's my pleasure and honor. Dr. M.B. Agarwal is a mentor and teacher for me. I remember when I was a professor of hematology at FMC Pune, we used to interact a lot between 2008 to 13, and even today it's because of Dr. M.B. Agarwal that we are having these education webinars, which are spreading knowledge throughout our country and even to the other parts of the world in such important topics of hematology. Well, we've already had the first talk, which was, I still remember the days when MapThera came first. It was 1 lakh rupees. And those days, 1 lakh was like 10 lakhs today for one injection of MapThera. And today we have the generic Indian available, and Dr. Nitin gave a fantastic talk on that. And the other topic is also so important. We've had the WHO 2022, where we got the blue book only this year in 24, as well as the printed version, as well as the ICC and MDS has taken a drastic advancement. We have the seekers chip all coming into the guidelines, and then the role of no dispoises, but you have cytopenia and you have the clonal hematopoiesis, it becomes MDS. So everything's, and that conundrum is going to be then discussed by our next speaker, Dr. Kamble. So I'm looking forward to this whole session, and I will not take much more time, so that the session is available for both question answers as well as for the next speaker, and then the discussions after that. Thank you.
Thank you so much, ma'am. And I would like to also tell you that I have heard your name many a times, and your students are here in Gujarat also working very
Yes, Dr. Karthik, my student, is there in
absolutely.
Gujarat. I was his guide. He was my DNB clinical hematology student in Gangaram Hospital. And Gangaram Hospital has the legacy because I took over this department in 2015 from my own teacher, Dr. Manorma Bhargav. And she started the DNB super specialty program in India. The first batch in 2009 started in Gangaram Hospital, and then the DNB hematology, now called DNB clinical hematology, spread to other centers. So, well, I am very lucky that for the last 10 years, I'm heading this department, which I took over from my own teacher, Dr. Manorma Bhargav. And we have had fantastic students coming out. Today, Dr. Ramesh Balasubramaniam is one of the discussants. He's my student who's now in Tamil Nadu, and he did a fantastic thesis on WHO, MDS, AML, WHO, shifting from the 2000 ELN classifications, the mutational work. We have such good hematologists in our country, and you have a beautiful gamut of discussants today. So I'm looking forward to the whole session. Thank you.
Thank you, ma'am. So sorry to keep you waiting, Dr. Nitin Sood. If any questions are there for Dr. Nitin, let's finish up with him first because he may have to leave also. So I request all our discussants to please put your hand raised sign so that you can start our question session with Dr. Nitin Sood. If any questions you have regarding him or want to advise, comment, please feel free over here. Well, in that case, there are no hand raised signs and there are no more questions from the audience. Well, I will go to the next speaker for the day, and that is no other than Dr. Neha Kamble. Dr. Neha Kamble, the screen is yours. Please go ahead. Thank you so much. And first of all, I thank Dr. Nitin Sood. Apology for the day. I joined late because of some miscommunication with the timings. Thank you so much for the fantastic lecture. And thank you for accepting as our guest speaker for the day. Thanks to you, Dr. Nitin Sood.
No,
Thanks.
thank you for listening and your attention. Thank you. Bye.
Thank you. Thanks a lot. Dr. Neha Kamble, the screen is yours. Please go ahead.
Thank you. Thank you so much. Good morning today, all afternoon, evening, everybody who's joined from different parts of the globe. To begin with, let me share my screen once. Yeah, so is it?
Yes, perfect.
Yeah, so we can see the whole screen, right?
Yes, perfect.
Okay. And just for the convenience of it, I'll switch off my video and get back after this. Okay.
No issues.
Great, great. Thank you. Thank you so much. And I'm thankful to all the participants who've come in at early morning on a weekend. And for these sessions, Dr. Nitin Sood had a wonderful session. And the next topic that we have to cover is diagnostic conundrums in myelodysplastic neoplasms and new modalities of testing. Am I not able to? Okay. A big thank you to Mumbai Hematology Group and a very big thank you to Dr. M.B. Agarwal, sir. Like just as Madam said, he's been a mentor to a lot of us and he's a dear mentor, and I thank him from the bottom of my heart for the kind invitation and for this opportunity to share my insights on the topic. So to begin with myelodysplastic neoplasms, it was MDS previously, myelodysplastic syndrome, and now with WHO Hemat Hem 5, it has been labeled as myelodysplastic neoplasm to stress on the malignant potential of it. But before I delve into the topic of MDS, I would want to brush up on a few basics because it's a bit difficult to maybe, comprehend the vast expanse of MDS and the newer updates that have come up in WHO Hem 5. So we begin with CHIP, so clonal hematopoiesis of indeterminate potential. This is quite a novel, new topics that have come up in the new WHO, CHIP and CAS that have been documented and in the textbook. So just a brief overview about CHIP. So with CHIP, we are looking at normal blood cell count. So whenever a patient who comes or rather CHIP, it's quite incidentally detected. So we have normal blood cell counts, and for example, there is a group of population who have got no detectable mutations, but on examination, they have low frequency mutations which do not have any potential to cause any disorder or disease, but they are there in the group of population. So with increasing genetic predisposition, background inflammation, cytotoxic exposure, immune attack, and smoking, a small population of this chip starts developing clonal population, right? So clonal mutations start happening in this group of population, and then they progress to either MDS or they can progress to a non-hematological sequelae. Also, there is other different population which have the sustained chip population and do not have any progression of the disease, and that is why we have dotted arrows for these, that they may or may not develop any sequelae. So MDS begins with a population with a chip mutation sometime back during their lifetime that they have had. Now we speak about CCUS. So CCUS is clonal cytopenias of undeterminate significance. So when cytopenias come into the picture, so you already have a clonal mutation pool. And when you start developing cytopenias, then you can label that population as to be having CCUS, right? So unexplained cytopenias, we need to rule out other causes due to which the patient may have unexplained cytopenias like vitamin or mineral deficiencies, hemoglobinopathies, autoimmune disorders, congenital bone marrow failure syndromes, toxic agents, infections, or anemia of chronic diseases. So we have a lot of confounding factors along with diagnosis of MDS whenever we are seeing a patient or whenever we are considering a diagnosis of MDS. So I believe before jumping to a conclusion of MDS, all of us need equal clear a diagnostician per se, right? So followed by a patient who has unexplained cytopenias and has some mutation pool of CCUS, you do a bone marrow examination or a karyotype analysis of FISH, and you see the mutational profile in this population. So VAF carries a lot of significance. We are going to discuss about VAF later on in the slide. So VAF, the number of mutations, and the driver gene mutations decide about the development of this CCUS population into development of AML, MDS, or MPN, or any other hematological parameters. After due examination, after karyotype and NGS, when you meet the diagnostic criteria, you can label this patient. If you do not find any mutation, it is then labeled as idiopathic cytopenias of indeterminate significance, that is ICUS. So ICUS, these needs to be reconsidered as non-neoplastic causes of cytopenias. So a brief general pathway of a normal population or a clonal pool from bone marrow of hematopoietic stem cells developing into AML is depicted here. So normal population hematopoietic stem cells are there, progenitors are there, blast cells are there, WBC levels are quite normal on periphery. So this is a normal presentation. So pre-MDS, CHIP and CCUS are considered as the, so like MDS is considered as the precursor state of AML. I believe CHIP and CCUS are considered as the pre-MDS states. So CHIP is, as we already discussed, there is no cytopenias, but there is clonality, which may develop into any hematological disorder, depending on the exposure of added factors like infection or chronic inflammation or any extra mutations. CCUS is where you have cytopenias as well, you have clonality as well. Finally, pre-MDS states of CHIP and CCUS develop into MDS, which are broadly divided into low risk and high risk, where there are derangements with your WBC or maybe your pancytopenia or cytopenias level, and there is increased clonality as well. And finally, there is progression to AML, that is leukemic transformation. So as we can see, the blast population keeps on increasing. So the blast count carries a lot of importance when we are talking about the morphological diagnosis of MDS. So up till the pre-MDS states, the blast counts or the blast population is quite within control. As we develop onto MDS states and the AML states, the blast count exponentially increase because the clonal mutations keep on accumulating, because the genetic mutations keep on accumulating. So on this knowledge, a brief general introduction about MDS is, it was called as MDS myelodysplastic syndromes, but now it has been updated to myelodysplastic neoplasms, and the short form is still kept as MDS and not MDN, to avoid the confusion, the phonetic confusion between myeloproliferative neoplasm, that is the MPN, because there is other category that is MDS MPN. So to avoid the confusion as MDN/MPN, MDS was for the phonetics convenience of it. So a unified framework of defining cytopenias is now adopted, and these definitions include hemoglobin less than 13 in a male, less than 12 in a female for anemia, absolute neutrophil counts of less than 1.8 for leukopenias, and platelets less than 150,000. So dysplasia is one of the major hallmarks of MDS. Dysplasia, the threshold has to be 10% for all the lineages and across all the MDS types, as well as for the myelodysplastic or myeloproliferative neoplasms. So dysplasia may be accompanied by an increasing myeloid blast in the peripheral blood, and on bone marrow, blast percentage always has to be less than 20. So the 20 cutoff is the one that differentiates the MDS states, the frank transformation, the AML states. The catch point to be considered this is the myeloid lineages which are affected by cytopenias in the periphery are not necessarily those that manifest dysplasia in your marrow. So as opposed to the contrary to the belief that probably if I'm having anemia, I should be having dysplastic changes in erythroids, or if I'm having leukopenia, I should have it in myeloids, is not the case. So cytopenias may be into some other lineages, dysplasia may be into some other lineages, right? So biology of MDS, I believe MDS spans so vast that it is impossible to understand the progression of the disease or the basic pathophysiology of the disease before knowing the biology of MDS. So this looks quite a complicated image out the biology of MDS, but I believe an inflammatory background stands quite in the center of it, right? It's mostly myeloid-derived suppressor cells contribute to the generation of reactive oxygen species, replication stress, genetic instability, and leading to the development of clonal evolution. So that is the reason why a recent study which was done in cardiovascular disorder patients, that they had a lot of CHIP mutations, because clonal hematopoiesis of indeterminate, or maybe even just clonal hematopoiesis, quite very much is commonly seen in these chronic inflammatory disorders. So it has been quite established, well established in cardiovascular disorders, not much into CKDs, but yes, MDS, or rather clonal hematopoiesis, stems from a chronic inflammatory background. And then there are interleukin-1 receptors that are an add-on to the entire process. So hematopoietic stem cells has two types, the long-term hematopoietic stem cells and the multi-progenitors. Myeloid progenitors, GMPs, MEPs, they are all progenitor cells that can involve in MDS development. And the regulatory T cells, natural killer cells, and damage-associated molecular patterns are also involved in MDS, right? So this is just a brief overview as to how the process starts and how the process continues. So now we come to the diagnosis. So diagnosis of MDS is quite a tricky thing to do unless you have a clearer idea as to what is not MDS. It's quite easy, you know, seeing a few dysplastic cells here and there, maybe on the periphery, on the marrow, and it's an elderly patient, and you are too tempted to maybe, you know, try to work it up for MDS, which is not the case. So I believe MDS majorly stems, or maybe the major support groups are dependent on the counts, the morphology, and the genetics. So counts, which indicate that there's a lot of ineffective hematopoiesis going on. Morphology, which indicates that a lot of functionally abnormal or dysplastic cells. So functionally abnormal cells, basically dysplasia is the functionally abnormal cells. And genetics is that there is a clonal disorder going on, or a clonal process going on. So we begin with counts. So it's a basic investigation whenever a patient with cytopenias, maybe isolated cytopenias or pancytopenias, bicytopenias, they come, a routine blood test is mandatory. So CBCs followed by a peripheral smear examination. Serum LDH levels usually are on the lower side, but honestly speaking, since we've been seeing a lot of MDS cases, I believe it does not stick to it, because there are a lot of hematinics that have been given up, a lot of intervention that has been already tried with this patient by the time the patient comes to a diagnostician or maybe a hematopathologist for a definitive diagnosis. So serum vitamin B12s to rule out nutritional defects, so quite a lot of times they're quite on the higher side, because if the patient is presenting with anemia, quite a lot of times they have been bombarded with just hematinics and no further workup to do with it. You should look out for history of drug exposure, as I said, hematinics as well. So diagnostic evaluation should always include a microscopic examination of adequate marrow and peripheral blood smears, coupled with one or more of the following. So chromosome analysis by conventional karyotyping of FISH, mutation analysis by next generation sequencing mutation profiling, and immunophenotypic evaluation by multiparameter flow cytometry. Multiparameter flow cytometry is not as advised as is the molecular and the chromosome analysis workup is, because it is not too specific, it is not too sensitive. But yes, there are quite a few sensitive clues about the maturation patterns which may indicate dysplasia in the case. So as we've already discussed, it is dysplasia in one or more myeloid lineages, threshold of 10%, and myeloid lineages affecting are not necessarily those that manifest dysplasia. So as WHO has been saying since all of these editions, so you should always have a 500 cell differential count of all the nucleated cells in a smear or a defined biopsy imprint, and a 200 leukocyte differential count from the peripheral blood, provided you do not have profound pancytopenias and leukopenias. So we come down to morphology. So morphology is we need to see dysplastic changes in either erythroid or granulocytic or megakaryocytic series. So erythroid series, it's you can see internuclear bridges, you can see multinucleation, karyorrhexis, nuclear budding, ring sideroblast. So if you're seeing ring sideroblast over an iron stain, it is quite an indicative factor of MDS. Granulocytic series, you can see pseudopelgohuae or hypolobated neutrophils, large A granular neutrophils, coalescent granules, hypersegmentation, or rods. So I would want to stress, when you're seeing OR rods, the blast count really does not matter. So when you're seeing OR rods with dysplasia, it is a very strong indicator and a very poor prognostic indicator of MDS, which I'm going to consider later on as well. And megakaryocytic series, you can see multinucleation, hypolobulation, mononuclear micromegakaryocytes, and widely separated nuclear lobes. So out of these three, whenever, personally for me, when I'm seeing a case for MDS, to begin with, I always try to have a look at the peripheral smear, if at all there are any clues, macrocytosis, LDH is normal, and the patient has had history of repeated transfusions and not responding to hematinics. These are one of the clues for me to very, see the marrows in depth, maybe if there is any dysplasia. To begin with, I always make it a point to start from megakaryocytic series, honestly speaking, because they're quite easy to pick up and they're quite sensitive and specific. So as opposed to erythroid series, quite a lot of multinucleation, binucleation, supposes there's a lot of hemolysis going on, and there is a hemolytic etiology or maybe an immune etiology. There are a lot of overlap diagnosis that can give you this kind of binucleated, trinucleated erythroids. So in case if you're seeing dysplastic changes in megakaryocytic, it's quite a specific and a sensitive indicator of a dysplastic process going on. So these are one more few very significant, very specific images of dysplasia that we are seeing. So these are all the nuclear blebs, or cytoplasmic maculation is not considered that significant, but yes, it could be seen in quite a few cases. This is the internuclear bridge that you see in erythroid series, and these are the ring sideroblasts. Also in megakaryocytes, this is a widely separated or a bilobe megakaryocyte. These are the micromegakaryocytes, and this is the nuclear lobe separation. So whenever we are seeing this kind of morphology, I believe at the same time we need to rule out other causes which may lead to this kind of reactive changes as well. So now, then we jump on to the third pillar of the diagnostics. So count and your morphology and genetics. So genetics is quite heterogeneous. So MDS genomic landscape is quite heterogeneous. It spans from mutations or from RNA splicing genes, DNA methylation, chromatin modifications, a lot of DNA response and repair mutations, signaling pathways, cohesion complex, transcription factors. So it spans over a large range, but yes, we need to focus on the most common MDS presentations that there are, and the molecular and the cytogenetic panels have been set keeping in mind about the most common findings that you see. So now that we are talking about genetics, I would want to speak a few things about variant allele frequency, because VAF is one of the most significant and the deciding factor whenever we are talking about these mutations, right from CHIP to CCAS to MDS. So a little information about VAF. It is still on, developing, because we started from some 2% VAF, and now when we are reached to a diagnostic category of around 50%, more than 50% VAF. So variant allele frequency, it is a measure of the proportion of variant allele in a genomic locus. So we are always seeing at one genomic locus how much of the sequence read match a specific DNA variant divided by the overall coverage of that locus, right? So however, VAF can be affected by many factors. So whenever a molecular hematopathologist is analyzing these kind of VAF, they need to be very mindful, because VAF is affected by assay variance, sampling, your assay design, cytogenetic changes at the allele as well. So VAF is a metric of the fraction of alleles carrying a specific genomic alteration. So this is the simplest definition of VAF that can be. And in detail, VAF refers to the proportion of sequencing reads that suppose a specific variant allele relative to the total number of reads within a genomic locus. So with this knowledge, WHO Hem5 has come up with major categories for your myelodysplastic neoplasm. So myelodysplastic neoplasm with defining genetic abnormalities, myelodysplastic neoplasm defined morphologically, and myelodysplastic neoplasm of childhood. For today, we are going to consider the first two, since there's a quite of diagnostic overlap between them, a lot of confusion as to which case has to be put in which category. So a lot of stress will be given on the first two. So, and myelodysplastic neoplasm or MDS classification, it has evolved over time, right from, we started from 1982 to 2001 to 2008, and finally 2016, and now 2022. So there has been quite a lot of evolution and a lot of molecular markers that have been picked up, a lot of molecular markers that have been identified, which are prognostically important, which are therapeutically important. So as we said, these are going to be the major categories that we will have a discussion about, beginning with myelodysplastic neoplasm with defining genetic abnormalities. So the first category, it consists of myelodysplastic neoplasm with low blast and 5q deletion, myelodysplastic neoplasm with low blast and SF3B1 mutation, myelodysplastic neoplasm with biallelic TP53 mutation. So keeping this slide over here, I would want to stress that when WHO said about low blast, you're expected to read between the lines that it is less than 5%, right? So myelodysplastic neoplasm with low blast and 5q deletion. So it is a myeloid neoplasm with cytopenia and dysplasia, chromosome 5q deletion occurring in isolation or with additional cytogenetic abnormality, but it cannot be monosomy 7 or 7q deletion. As I said, low blast is less than 5% in the bone marrow and less than 2 in the periphery. So this is something that you have to understand between the lines, that the blast count cannot cross 5% in marrows, and 5q deletion alone or with one other abnormality other than monosomy 7 or 7q deletion. So this is a very lovely article wherein there are phenotypic cues that predict the cytogenetic or abnormalities in myeloid malignancies by Michael Stone and his colleagues and his friends. So this is a case of MDS deletion 5q, where you see megakaryocytes with non-lobated or hypolobated. So dysplastic megs are very commonly seen with myelodysplastic neoplasm, low blast, and 5q deletion. Other features that you can see is maybe absence of or CBC, and hypoplasia. So these are all the dysplastic mix that we were talking about, all of these. So this is a hypolobated. This is quite a lobe separation. It's just 2 lobes, and this has got no lobe separation at all. Okay, great. So anemia, which is often microcytic and transfusion dependent, as we've already discussed. So thrombocytosis is present in 1/3 of the cases, and thrombocytopenia is quite uncommon and reflects an advanced disease. So that is the reason why you're seeing thrombocytosis in the periphery and quite a lot of dysplastic megakaryocytes in the marrow. So bone marrow is usually normocellular or hypercellular and frequently exhibits erythroid hypoplasia. Megakaryocytes are usually increased in numbers and normal to decreased in size with conspicuously non-lobated and hypolobated nuclei. So this is one of the phenotypic clues, for example, in a resource limited wherein you cannot, or maybe even a financial restraint setting wherein the patient does not have that kind of finances to maybe do the specialized workup. So these are small little clues that may indicate the molecular marker that you may expect. So if you're seeing quite a lot of thrombocytosis, because usually in ADS cases, they have cytopenias in the periphery. So if you're seeing thrombocytosis and a lot of dysplastic megs and erythroid hypoplasia, so it could be 5q deletion, it could be a predictive 5q deletion, right? So in contrast, dysplasia in erythroid and granulocytic and erythroid is quite now, and significant granulocytic dysplasia is uncommon. So with this, we shift on to with glioblast less than 5% and SF3B1 mutation. This B1 is quite specific, strongly associated with ring sideroblasts. So myelodysplastic neoplasm with cytopenias and dysplasia characterized by SF3B1 and often ring sideroblasts, less than 5 bone marrow and less than 2 peripheral blood blast. There's absence of 5q deletion, monosomy 7 or a complex karyotype. It may be associated, SF3B1 may be associated with other mutations, but if you're seeing SF3B1 and a ring sideroblast, it fits into this category. So MDS with low blast and ring sideroblast is an alternative for cases with wild type and more than 15%. So the cutoff for these ring sideroblast is more than 15%, and they should cover a minimum 1/3 of the erythroid circumference under discussion. So erythroid precursors on a very good Persian pearl stain, I believe you should always have a control with that. So far in my practice, I always have an iron control whenever we are doing a pearl stain for bone marrow samples, especially for cases of MDS and this kind of picture. So even if more than 1/3 of the erythroid precursors need to show ring sideroblasts, and it is quite specific marker for SF3B1. So, but there are a few cases you do not find SF3B1 mutation, but yes, if you're having more than 15% ring sideroblast, even that counts as MDS with ring sideroblast. You may not have SF3B1. The clonal pool may be quite less, but yes, if it is more than 15%, covering more than 1/3, you can put it into this category. And myelodysplastic neoplasm with biallelic TP53. So this is quite, TP53 has been the center of discussion in quite a lot of malignancies, be it solid, be it liquid, be it blood. So TP53 is inactivation or TP53 mutations. It's they have a host of presentations whenever we are talking. So for MDS with biallelic, so biallelic, that means it is affected both the alleles in the patient. So it has to be less than 20% blast and less than 20% peripheral. Complex mutations and cytotics. So TP53 carries a lot of friends along with it. It carries mutations along with it. TP53 is a term that needs to be clearly understood by residents or maybe trainees whenever they are going through these kind of cases. So multi-hit is either you have 2 TP53 mutations or VAF. So here is the VAF that we were talking about. So even if you have 1 TP53 mutation with a VAF of more than 50%, it can fit into this category. Or 1 TP53 mutation with 53 number or loss, it can be fit into this category, or 1 TP53 mutation with a 17p loss, right? So in either which ways, for it to be multi-hit, one has to be absent or one has to be mutated, right? And MDS biallelic TP53 takes the precedence over MDS 5q and SF3B1. So as we've already discussed, that SF3B1 can be associated with other mutational, other cytogenetic abnormalities, and MDS 5q as well. But whenever you're talking about MDS biallelic TP53, even if you're seeing a 5q deletion, even if you're taking SF3B1, once you have a biallelic TP53, it goes into this category. Right. So the second category that we would be discussing is myelodysplastic neoplasm defined morphologically. So broadly, they are classified into 3. Again, MDS with low blast, myelodysplastic neoplasm hypoplastic, and myelodysplastic neoplasm with increased blast. So this is a tricky category because with increased blast, it becomes very difficult for a diagnostician to maybe label them into an overt AML or maybe keep it into the EB or IB2 category. So to begin with, myelodysplastic neoplasm with low blast. Again, as we said, low blast is less than 5 in bone marrow and less than 2 in periphery. They can include any genetic landscape abnormalities except SF3B1 and a multi-hit TP53. So once if you have multi-hit TP53, even if your blast less than 5%, it goes into the earlier category. And even if you have SF3B1 with low blast, it goes into the earlier category of ring sideroblasts. So the second is myelodysplastic neoplasm hypoplastic. So from the term, we understand the marrow is going to be hypoplastic, as opposed to the other categories where you have cytopenias in the periphery and a cellular or maybe a hypercellular marrow. So cytopenias and dysplasia characterized by significantly decreased age-adjusted bone marrow cellularity as determined by biopsy. So the term age-adjusted bone marrow cellularity carries a lot of meaning into categories like these. So hypoplastic or HMDS is how it is written, is driven by a selective growth advantage of somatically mutated clonal hematopoietic stem cells or progenital cells. And the hypoplasia may be driven by a T cell mediated immune attack on hematopoietic stems and progenitor cells with oligoclonal expansion of CD8 plus T cell, overproducing interferon gamma and TNF alpha. So this is the reason why I was keen on covering the biology and the immune component of MDS earlier, because in all of these categories, these are quite functional, especially hypo. There is a lot of immune dysfunction and immune attack going on in the background. And there's a significant overlap with PNH and aplastic anemia is reported clinically as well. When PIGA mutation is demonstrated in the absence of bona fide features of MDS, classified as PNH. Okay, so you do not label them if you're seeing PIGA mutations and there is an overlap between PNH. So it is not wise to put them into this category. They should be labeled as PNH per se. So bone marrow cellularity, as we discussed, the age-adjusted bone marrow cellularity, it has to be below 30% of the normal cellularity in a patient younger than 70 years. Or it has to be below 20% in an aged patient more than 70 years. So 70 is the cutoff that they have kept. Less than 70, if it is, it has to be below 30. If it is more than 70, it has to be below 20. Dysplastic features are identified in one or more hematopoietic lineages, but honestly speaking, it becomes difficult because the marrow is quite hypoplastic. And megakaryocytes may be scattered and they form loose clusters with usual features of megakaryocytic dysplasia, including small size and nuclear hypolobation. And the presence of micromegakaryocytes is not that common in this category. So you may see dysplastic megakaryocytes, but micromegakaryocytes are not that commonly seen. So this is one of the special categories where cellularity is quite opposite or quite opposing to the other categories that we have. Next category is myelodysplastic neoplasm with increased blast. So this was EB1 in 2017 and EB2, which has not much changes, but it is now labeled as IB1. So MDS with increased blast 1, there's more than 5 and less than 10% blast in the bone marrow, right? And more than 2 and less than 5 in the peripheral blood without significant reticulin fibrosis. So whenever we are looking at increased blast 1, wherein the cutoff it is between 5 to 10, you shouldn't have a significant reticulin fibrosis, because then the category changes again once your fibrosis becomes grade 2 or grade 3. And MDS with increased blast 2, again, the cutoff is more than 10 to 20 in the bone marrow and 5 to 20 in the peripheral blood. So all cutoff cannot cross more than 20 without significant reticulin fibrosis or with presence of all rods. So I would want to stress on this category of MDS IB2 because we were not discussing about ICC per se, because majorly I believe WHO is followed by the diagnosticians per se, and MDS IB2 category, that is the 10 to 20 or rather 10-19%. In 20, we would as 19. So 10 to 19% category has been labeled as MDS/AML for ICC. So that's the only difference between IB2, which is there in WHO, and MDS/AML, which is in the ICC classification. And the third category, when you start having fibrosis, is MDS with increased blast and fibrosis. So blasts are again 5 to 20% in the bone marrow and 2 to 20% in the peripheral blood, with significant bone marrow fibrosis defined by WHO grade 2 or 3. And it can include any genetic landscape, but again, it cannot have SF3B1 and it cannot have a multi-hit TP53. So the problem with MDS with increased blast and fibrosis is quite a lot of times taking samples or maybe acquisition of your samples becomes quite difficult. And you have quite a lot of times you have hemodiluted aspirate smears, and then you have to rely on only on the bone marrow biopsy for the diagnosis, because once you have a hemodiluted smear, you are not having a very clear idea about the blast percentages as to if it is more than 20 or probably less than between 5 or 20 or 19, 18, whatsoever. So what is suggested is probably if you have a good enough biopsy, you can try to do a CD34 on the bone marrow biopsy to have a better evaluation of the blast percentage along with the reticulin fibrosis. So this is one of the problems that we face. There were a few cases. We had a very young female who was repeatedly, she was a dry tap. We couldn't have a lot of aspirate with her. It was quite hemodiluted quite a lot of times, but then biopsy was full of cells. And so we did it was the second marrow that we did when we couldn't have any aspirate for any molecular studies. The first marrow was done almost a year ago, and there was a difference of 1 year between the two. So when we did on day one, the marrow was quite cellular. It was not that difficult. Fibrosis had not developed, but she had multi-lineage dysplasia. So all the 3 lineages, and which was quite unusual for a young female. I believe she was 37 years old, and unfortunately, due to financial restraints, we cannot go ahead with her molecular and cytogenetic. The same female came back to us after 1 year, and when we did a marrow procedure for her, repeat marrow procedure, she had developed a lot of marrow fibrosis. So again, the aspirate could not be collected. It was quite hemodiluted, and the biopsy showed quite a lot of increased blast. But due to financial restraints, unfortunately, we couldn't go ahead therapeutically with her. Hopefully, she's doing well. But this is the major problem that we face whenever there is increased fibrosis and MDS, or there's this overlap between MDS and AML with these cases. So to have a better idea, it's always advisable to do a CD34 because to have maybe a generalized view of the blast percentage that is there. So this is just a consolidated table of the MDS with defining genetic abnormalities and morphologically defined. So again, the 3 categories, low blast and 5q deletion. So, and low blast and SF3B1 and biallelic. So first 2 categories, the as we do, it can be 5q deletion or with any other abnormality apart from monosomy 7 or 7q deletion. And it can be any mutations except multi-hit. SF3B1, again, it applies the same thing, that there is absence of 5q or monosomy 7 or complex deletion. And biallelic is usually TP53. With biallelic TP53 is usually complex. As I said, TP53 carry a lot of friends along with it. So quite a lot of times there are a lot of overlapping mutations to see along with TP53. And morphologically defined, again, low blast less than 5%. It can be any except multi-hit TP53, SF3B1, and increased blast is IB1 and IB2, and MDS is fibrosis. It can be, again, it is except multi-hit TP53 or SF3B1 with a grade 2 or 3 marrow fibrosis. So risk stratification that is followed. So due to time restraints, I will not be going into much detail about the IPSS, IPSSR, IPSSM. There are very good online calculators that are available as to how you reach out to a score for IPSSM, maybe IPSSR. I am rather speaking about the risk stratification directly. So low risk as opposed to WHO 2017 and WHO HEME 5. So the first, there is low blast with SF3B1. So it was labeled as MDS RS most cases. It is a low risk MDS. In fact, it's got a good prognosis. MDS with low blast and isolated 5q deletion was called as MDS deletion 5q in 2017. And this category of low blast sideroblast and hypoplastic. It was called as single lineage, multilineage, or MDS ring sideroblast with SF3B1 wild type. That is more than 15. That is, you have more than 15% ring sideroblast in absence of SF3B1 mutation. So, honestly speaking, with WHO Hem5, single lineage, multilineage dysplasia is not too stressed on. But yes, whenever you're reporting, it is always a good thing to maybe document it on paper, because like I said, the patients quite a lot of times they lose follow-up, they come back to you. So you have an idea as to how the disease has progressed. Maybe single lineages have gone into multilineages, or probably the disease has progressed or worsened. So you have a documented idea on those lines. So I believe always try to mention what lineage is showing what kind of dysplasia. It is much more useful to the diagnostician rather than the clinician in these cases. So WHO Hem5 does not stress much on the single lineage, multilineage as such. And the high risk category, that is the MDS with increased blast 1, increased blast 2, MDS with fibrosis, biallelic T53. It was just EB1 and EB2, and MDS unclassifiable has been entirely taken out of this and put into the other category. So this is the early prognostic models. Like I said, we started from 1997 from IPSS to WSS. This was an intervening model that started, and finally IPSSR in 2012, and now we have IPSSM in 2022. Very great minds have worked on the IPSSM risk stratification, and it's a very lovely model, a very lovely calculator that's available online, and you can predict the survival outcomes and the years of survival and things like that. And the risk stratification becomes easier for the clinician per se, because it becomes easier to predict the response to therapy by the patient. So prognostic impact of mutations in MDS, as we said, SF3B1 has got a very good favorable prognosis. Neutral or unknown prognostic impact is found in the newer molecular markers, the IDH1, TET2, BCOR, ETV6, GATA2, U2AF1, which is quite commonly associated with your VEXAS as well as ZR, ZRSR2, RAS, and STAT2. And adverse prognostic factors, as I said, TP53, EZH2, DNMT3, AXXL1, RUNX1, SRSF2, CBL. So whenever we are seeing these kind of molecular mutational landscape in patients, they are quite commonly associated with increased blast count, surely less than 20, but on the higher side. And mutational function that are affected are DNA damage response. We've already covered this. This is just a reiteration of already said things. So this is just a pictographic evaluation, because there's a lot of confusion about what category has got what blast and what peripheral blood. So to keep it simple, bone marrow blast percentage have been considered over here. So CCUS is on the center of it. So clonal cytopenias of undetermined significance, not even CHIP, because CHIP is just clonal hematopoiesis. Which may or may not lead to MDS, which may or may not lead to cardiovascular disorders, which may or may not lead to chronic inflammatory disorders, which may or may not lead to CKD. So CHIP is quite vast as to in what direction it will go ahead. But yes, CCUS has been very commonly associated with the sequelae that it follows. So the center is always CCUS, clonal cytopenias. There's no increase in blast. It's just cytopenias. There is no increase in bone marrow blast. But then now, when CCUS develops and goes ahead, these four categories, that is MDS deletion 5q, MDS low blast, MDS SF3B1 with low blast, and MDS biallelic TP53 with low blast. So blast cutoff is less than 5. So these four categories, the one that fall in the inner circle, they are less than 5% blast. So whenever you're having less than 5% blast, you may predict that the MDS can be classified into either of these four categories. Once your blast cutoff, your blast crosses 5, so it is 5 to less than 20, you go into the category of MDS EB, either EB1 or EB2, depending on if it is less than 10 or more than 10, but less than 20. And yes, again, if it crosses, it is frank more than 20, you have a leukemic transformation, that is AML MRC. You have gone into a myeloid leukemia with a myelodysplastic related changes. So this I find quite easy to comprehend with CCUS as the godfather of them all, and with the blast percentage cutoff. So to begin with, rather than focusing on what category to put it, I believe to begin with morphologically is very important to be sure about the blast percentage. So, and quite a lot of times there is a lot of variable distribution of blast percentage on a smear as well. So on an aspirate or an imprint. So I believe as diagnostician, as a hemat pathologist, it's very crucial that you go through the slide quite well extensively so that you do not miss out on the pockets of blast that are there. Quite a lot of times it may be a technical thing or maybe just a smearing difference. Probably you smear it and the blast get carried to the end of the smear and then you feel, okay, fine, not many blasts are there. So I believe a thorough view of the aspirate and the imprints is the cornerstone of maybe suspecting a case of MDS, because there's a very thin line when the blasts are less, probably, between 5 to 10%. So 5, 6, 7, it's you tend to not be too keen to maybe cross that 5. So less than maybe 5, 6, 7 or less than 5, it's a very tricky place to be. So a thorough evaluation of the aspirate smears morphology to begin with is very, 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 very important before we jump into all these 3 circles. Right. So now we jump on to the newer modalities of testing. So as we know, as we've already discussed is morphology, its counts, its genetics. So genetics, the commonly done panels are DNA or NGS panels for molecular profiling, and you do cytogenetic analysis. You do FISH, or you're doing chromosomal banding assays. So we all know that. I'm not focusing on the routine conventional that are already being done, but the newer modalities of testing are required. Again, why? Because the genetic landscape of MDS is so vast. It is probably changing, even just as we saw right from 2012, the IPSSR and the IPSSM, there have been a lot of mutational markers that have been identified. So there is a need to find these newer modalities of testing. Firstly, for diagnosis, because conventional NGS, though we are speaking about the common mutational profile that we see in MDS, a lot of SNVs get to be missed with the conventional molecular and cytogenetic testing. But yes, these newer modalities of testing probably can focus on these SNVs. So for example, if you clinically you have a strong suspicion of MDS morphology, it's clearly more than 10% dysplasia in the lineages, and you are seeing maybe blasts as well, but somehow your NGS turns out to be negative. So you have to have that kind of suspicion. Okay, fine, these could be the SNVs that are being missed by the conventional testing. So, but that is the last resort when probably the clinician has tried all or maybe ruled out all the other possible etiologies of dysplasia that could be with it. And after ruling that out, but still, if you are clinically and morphologically as a diagnostician being very strong that it is MDS, you need to look out for the SNVs as well. Which are not that common, but yes, they tend to be missed in quite the few rarer cases. So newer modalities for testing are basically to detect those missed out molecular mutations by the conventional testing, and also to predict or maybe to decide about the MRD status in MDS. So it's quite a new thing, that MRD in MDS, and it's quite evolving all through the time. Again, it is a problem because VAF you do not have a standardized or a validated guidelines for VAF, even for MRDs. So it becomes a little tricky to maybe just rely on the molecular markers to, decide on the MRD. It should always be coupled with what you're seeing on maybe as clinically, or maybe on your counts, or maybe on your morphology, and along with that. So MDS, I believe, is not just one test as a whole. It's quite 3 or 4 together, and maybe a holistic approach for diagnosis. So as we said, flow cytometry is not that routinely done, but yes, this is a very lovely article by Uta and colleagues. This was published in February 2024. So MDS PB13 score. It is a 13 parameter flow cytometry that they have an entire panel, and they actually do this in cases who have been diagnosed on NGS, who have been confirmed on NGS and your cytogenetic testing. So they wanted to see the sensitivity and specificity of these flow cytometry markers, and how flow cytometry can aid in the diagnosis of MDS, because they aim to do this on a peripheral smear and not a marrow, to avoid the invasive procedure. So MDS PB13 score, it combines the detection of FCM aberrancies in different cell populations to suggest the presence of MDS in blood. This score offers a preferability test reliability as a part of integrated diagnostics in blood. It may represent a less invasive tool to guide further diagnostic steps in patients suspected of having MDS. So 13 score, it must be validated in a multi-center setting. which is planned along with the ELN IMDS flow working group. So, but this is still in development. I just thought it is quite a lovely thing to share, and I would urge you to go through this article. So it is a combination of 13 FCM parameters with the best diagnostic accuracy is termed as MDS PP13 score. For each aberrant, 1 point is added up. So some score of more than or equal to 3 defines the threshold which is suggestive for MDS. So this is a lovely approach maybe to begin with. If people who are interested can go through it, can try to do it. So it correlates with your IPSSM categories, and the correlation, the significance is quite there. So more than 3 with the lower categories 36% and 64%, and with the higher categories 82% and 18%. So the team found it is quite in correlation with what you see on your IPSSM stratification or your molecular findings. Secondly, the MRD in MDS. So MDS exhibits not only, as we already discussed, not only DNA-based genetic abnormalities that could be detected by NGS, but also heterogeneous aberrations related to the immunophenotype, gene expression, epigenetics, microenvironment, immune response. So a lot of bone microenvironment is involved whenever we are speaking about evolution of MDS. So achieve analytical sensitivity to assess deep molecular responses, error correction by unique molecular index and bioinformatics analysis during variant calling, as well as separate tagging of forward and reverse strands are recommended for MRD detection. So it's a little too maybe in detail, but we would be just covering the names of it. So level of circulating tumor DNA is one of the approaches that are used to detect MRD in MDS. It is calculated from concentration of cell-free DNA and the mean VAF. So again, VAF. So VAF is if sequence is the father of them all, VAF is the mother of them all. And the mean VAF of mutations detected in cell-free DNA has had high concordance with the mutation profile, and the VAF detected in the bone marrow. So quite a lot of newer testing are trying to pick up MDS or trying to indicate the presence of MDS in the marrow on peripheral blood to avoid the invasiveness of the procedure, and which is a tricky thing to do, because it's quite difficult when you have profound cytopenias, leukopenias. It becomes a bit difficult, but then it's fine if the tests need to develop a high sensitivity, specificity. The VAF needs to be worked on, needs to be standardized, needs to be validated for these tests to be routinely used. Single cell sequencing is one of the platform, microfluidics, microdroplets, plate-based nanowells, fluorescence, input. So all of newer technologies paper, I think this coming October 2024, measurable minimal residual myelodysplastic neoplasm. So now we jump onto the cytomic based detection of mRNA assays and fish are single nucleotide polymorph homozygosity that are not detected by standards. A newer modality that has been worked up into this is optical genome mapping. So optical genome mapping has already been utilized for a few of the other disorders, maybe not too into routine practice, but for hematological malignancies, it's still being developed. So optical genome mapping, it's a novel non-sequencing based technique. So why the upper hand that OGM has is it helps to detect those SNVs that are being missed, probably maybe missed. So it enables detections of all SVs by evaluation of patterns generated by fluorophore label tags to specific 6 base pair sequence motifs with an extremely long DNA. So the advantage is this: you are not breaking the DNA in any way. So you're seeing the DNA as a whole. So there have been lovely teams in US, my colleagues in US, my colleagues in Europe have been working a lot on optical genome mapping. I'm sure quite a lot of teams in India have been working on that as well. But we have not yet come to maybe a diagnostic guideline or maybe an interpretation guideline to work up with OGM. And in fact, OGM is one of my proposed topic for my PhD thesis as well. And I hope we come up with quite good information, and we hope we come up with a multicentric study. So it's going to be a multicentric study with my colleagues and me here in India, and hopefully we work out a lot of data and a lot of interpretation guidelines with that. So MDS is characterized by a high degree of somatic genetic alterations. Rating, we've already seen this, and large size structural variants. So SVs are defined as genomic alterations greater than 50 base pairs that encompass copy number variants, insertions, inversions, gene rearrangement, complex genomic alterations, and copy neutral loss of heterozygosity. So this is just a brief overview as to how the entire maybe the flow of OGM goes along. So you have to have a high molecular weight DNA extraction, and then you label them, and then you linearize the labelized DNA molecules, you record the images. There's a lot of bioinformatics involved in OGM. So I believe the instrument itself is in crores. So there's a lot of bioinformatics involved in this, and a lot of rather a lot of keen eye to have to maybe pick up what we are looking at. So the conversion of images in molecules, and there's rare variant pipelines. You see the SV and CNV calling an annotation. You compare it with the whole genome interface and a genome browser interface, and you plot it on circus plots. So quite vast topic maybe to delve into, but yes, this is one of the promising technologies, because as opposed to the general understanding that cytogenetics is quite obsolete is what is maybe understood. But I believe cytogenetics is still in the center when we think about diagnosing cases like MDS, which has got such a huge mutational landscape. And I think OGM is one of the promising. So just as the NGS is in molecular techniques, so OGM is the NGS for karyotyping is what they say. So what points to consider when making a diagnosis of MDS? So I would believe what to rule out before you diagnose MDS, right? So therapy-related MDS, you need to have a history of cytotoxic therapy or irradiation, maybe any prior malignancy the patient must have had, drug-induced cytopenias, B12, folate, zinc, copper, your nutritional deficiencies, or excessive alcohol intake as well. They lead to a lot of macrocytosis in the peripheral smear, but then LDA should be a little on the higher side. Exposure to heavy metals also lead to this kind of a dysplastic marrow features. Infections, viral infections like HIV, Epstein-Barr virus, hepatitis C, parvovirus, which is quite commonly associated with the erythroid hypoplasia, and leishmaniasis. Hemophagocytic lymphohistiocytosis is also one of the overlapping features, because you see a lot of cytopenias in cases of HLH. So it's very important to maybe pick HLH to work on MDS and lose time, because HLH can be quite well taken care of if it is picked up quite early. And then there's anemia of chronic disorders. If there's any background inflammation, infection, cancer, autoimmune cytopenias, metabolic disorders, other hematopoietic stem cell disorders like AML, myeloproliferative neoplasm, aplastic anemia, PNH, or LGA leukemias, and constitutional disorders or syndromal disorders like CDAs, sideroblastic anemias, Fanconi's, or Down syndrome. So there's a whole list of maybe age-appropriate diagnoses that a diagnostician needs to have, labeling any kind of dysplasia as MDS, because it's in a whole lot of other disorders, and we need to have a keen eye for that. So with this, I finish my talk, and I hope I would love to take questions if there are any.
Thank you, Dr. Neha Kamble, for that wonderful presentation. You made the whole complex topic so easy. And very important, the pictorial presentation of the MDS EB1, EB2, CCUS, and all less than 5% blast. That was quite beautiful. Thank you so much for making this complex topic such a wonderful way of presentation. Wonderful. Hats off to you. Thank you. Thanks a lot.
Thank you.
And
Thank you so much.
now,
I would want to add to this. I was in the similar position as many of the trainees are with regards to MDS, but I have been blessed with lovely mentors, and I have been blessed with mentors who have worked so much into this area that it becomes easier for me to comprehend, and it becomes easier for me to maybe predict as to what new should be brought around maybe 5 years down the line, or maybe 10 years down the line, where we are lacking at. So I feel I'm living the best of both the worlds, and I get to know information, because I'm working on a lot of projects which are happening right now, probably, which then turn out into guidelines. So it's quite a privilege for me, and quite I'm honored to have blessed with lovely mentors who have this kind of clarity, and then that clarity passes on to me.
thank you. Thanks a lot. Can you please share your screen once so that we can see each other?
Yeah. Just a second.
I also request all our discussions to please put the raise signs. And meanwhile, as the question come on, I just wanted to clarify one thing. You mentioned about MDS with fibrosis. These are the patients who have got fibrosis grade 2,
Yes.
grade 3 in the bone marrow. Plus, they've got peripheral blood blast of more than 5%. Am I right?
Yes.
So if the
But they're less than 20.
but less than 20. So
Yes.
if it is grade 2, grade 3 fibrosis with a peripheral blood blast of less than 5%, then what should we call it as?
I would rather suggest to maybe decide both.
Your voice is breaking, Dr. Neha.
A simple CD34 IHC enumeration. Oh, okay, just simple now. Yeah.
Uh, it was breaking. Can you please repeat your statement?
Okay, so if you're talking about fibrosis in the marrow, I would not want to stress on the blast percentage on the periphery. I would always want you to do a CD34 enumeration on the bone marrow biopsy to have a better idea about the blast percentage.
Okay, so if it is less than 5%,
I'm
still we
sorry.
are going to call it. If it is less than 5% in the peripheral blood or bone marrow, still we are going to call it as bone marrow with fibrosis, MDS with
No,
fibrosis.
no, we cannot. We cannot.
We cannot.
We
Okay.
cannot.
Thank you. Thank you so much. Dr. Shweta, your question, please. Dr. Shweta Rajpal.
Yeah, can you hear me?
Yes, please go ahead.
Yes.
Okay, yeah. So wonderful talk, a lot to be covered in MDS. So I'm actually working in Tata Hospital. So here, day in, day out, actually we do flow for MDS, diagnostic as a diagnostic modality, and it actually helps us a lot. So that way, the thing like flow being a newer modality is something maybe like you know flow is something that is actually in practice is what I would like to emphasize for the students that way. And one more thing that I felt for MDS, any class on MDS, important thing is that now, even though blast being less than 20%, we always have to rule out component of AML with recurrent genetic abnormality, which may otherwise look as MDS. So that part I think for the benefit of students. So these 2 points I wanted to add, and for the this thing for optical genomic mapping, what is the frequency of cases in which it would have helped, or what exactly, which way it would help, is a question that I would like to ask Dr. Neha.
Okay, so if I get you correctly, you mean to say as to how many minimum, patients we need to go through maybe to establish the utility of OGM.
Uh, yeah, or maybe out of 100%, what is the percentage in which OGM would help in cases of MDS?
Okay, great question. So I would want to add to this is OGM per se itself as a single modality of testing is not helpful.
I
So
think any
any testing, exactly. So any testing per se is not going to be
multimodal
helpful.
testing.
With OGM, the thing maybe researchers all over the globe are planning to establish or maybe aiming to establish is how correlatable OGM is to the
Mhm.
conventional NGS or to the conventional karyotyping, right? And if there is any additional information that you can pick up on OGM, which is being mixed up by the routine testing. So
Mhm.
probably OGM is not something that I would not see it into practice in the next maybe 5 years. But yes, once we have a lot of data on OGM,
Right.
a lot of samples and rather a lot of geographically separate populations, I would say. So Asian population, maybe US, maybe UK. So when we have that kind of heterogeneous data, and only then we can be able to maybe state if it can be. But I believe it's got a good potential because, as you said, SNVs we miss quite a lot. Quite a lot of times we had a case who was clinically looking MDA, not responding, molecular.
Dr. Neha, there is some problem.
Yeah, I thought maybe if my internet connection is a problem.
Neha, you can close your video. I think that would be better.
Much fast.
Dr. Neha, we cannot hear you. Dr.
So I
Neha,
believe OGM per se as a single is not advisable to do. Yeah, am I audible?
you are audible. If you can close your video, that would be better because your voice is breaking.
Okay.
If you can close your video.
Okay, I'll do. Yeah. Yeah, is it okay now?
Yeah, better now.
Hello?
Yeah. Yeah,
Yeah,
it's
okay.
better.
And
It's better.
the second thing about flow is, yeah. So the second thing I wanted to add about flow is, so for example, in Tata, quite a lot of
I think we lost you again. Can't hear you.
Dr. Neha, we are not able to hear you.
to choose a specific.
Yeah.
Oh God, yeah. Hear me now?
Yeah, we can hear you, but in the middle, we
Just a
can
second. I'll just.
breaks. Yeah.
Okay. Okay. Please give me a minute. Okay. So meanwhile, I'll keep talking just in case. So with tree.
Yeah.
Who are doing it on maybe on a daily basis diagnostics, but when the resources are available for a resource poor setting, wherein MDS, so flow cytometry in MDS would be a supportive
Correct, correct.
evidence rather than, yeah. So
Yeah,
if there
yeah.
is a resource poor setting, I would rather, so honestly, for my patients, I would not go ahead with a flow in the first go. I would always go ahead with a NGS or a molecular or a cytogenetic study. If the money is too low, I would rather begin with a karyotype, a basic fish or a basic CBA, rather
Correct.
than even spending money on NGS or flow. So I believe flow does support the diagnosis, but I believe flow does not put a pen on it, honestly speaking. So even when you do a flow, you are seeing dysplastic patterns, you need to know what molecular markers you're looking at, because the entire prognostication, the entire therapeutics depends on those prognostication as well.
Correct. But in scenarios where, you don't get anything on molecular, but on morphology and flow you have got, you at
Yeah.
least have the confidence that, yes, you have something for
Absolutely.
diagnosis per se, that way. So that way it helps. And yeah, resource constraint setting, then obviously you'll have to prioritize, but definitely it helps in settings where when you are at this thing, when you have to counsel the patient, flow
Mhm.
comes earlier than the molecular, which will take some 2 weeks, 3 weeks minimum time, depending on
Yeah.
where you are working. So
Yes.
that way, it does help. Of course, resource constraint setting, we have to prioritize, and then, of course, flow wouldn't be considered then. But whenever it is possible, we always try to do it. Yes.
And to add to this, just one point, even before we jump on to do a flow, even before we jump on to do a molecular, morphology stands on
Definitely,
the basis
definitely.
of it. So
There's no looking back for morphology. Morphology
exactly,
can
exactly.
never be replaced. That is the key. Like you start from there and then go towards
I
anywhere
know,
else.
I know, I know. So I would love if hematologist can maybe confidently say just on morphology, ruling out the other confounding factors that may have dysplastic features on marrow, that yes, this could be an MDS. So like I said,
Mhm.
5q deletion, there's a very typical morphology, phenotype morphology and molecular correlation that can be seen. So I believe these little clues really help in a resource poor setting. And to add to this, if it is a resource poor setting, it is the same on the therapeutics as well. So if a patient does not have enough money even for the basic tests, chances are he may not have money for the treatment as well.
Treatment. Correct.
Exactly.
Yeah. Thank you. Thank you,
Okay,
Dr.
thank you. Thank you so much.
Thank you, ma'am. Thank you, Dr. Neha. Dr. Vidisha Mahajan, your question, please.
Yes, hi, Dr. Neha. So there was a mention of somewhere of using of flow as an MRD purposes for MDS. Can you just highlight how can it be used? And if we've diagnosed a case on flow, do you actually see that there's regression of all the dysplastic changes on flow?
Okay, great question, Dr. Vidisha. So as I said, I am not too keen on doing flows for MDS, and I would not be too keen on doing MRDs on flows for MDS, honestly speaking,
Any
because
experience from Dr. Shweta on this?
For MRD, currently we are not doing a flow for MDS, but however, like in case we get such sample, we see that the disease, like, persist, like dysbiosis persist in MRD if we are monitoring. But for MDS, we are not monitoring these patients for MRD by flow cytometry currently.
Thank you. Thank you so much.
Yeah.
Thank you, ma'am. There are some couple of questions from the audience. Dr. Gopinathan wants to know regarding the blast percentage. Would you quantify it by morphology or by flow cytometry?
So it depends. If it is frank less than 20, so more than 10, less than 20, I do not see any importance of, putting a patient's money into flow. But yes, if it is less than 5, or maybe you are there, just like I said, 5, 6, 7, 8. So that less than 5, more than 5, अरे देना है नहीं देना है. Even for that, if you have that kind of, if you can spare your resources, maybe to just run a tube, that is fine. But honestly speaking, it is not the need of the time, because honestly speaking, if the blast percentage is that low, probably the patient is into low risk. So honestly speaking, a low risk patient is not to be attended to with the urgency as much as maybe 18 or maybe 19 or 20% plus case has to be. But yes, I would rather, maybe if possible, if it is possible for you in a resource setting, if you can run a tube, well and good. But probably in low risk or maybe low blast, I would not recommend doing it. But yes, if you are in that 5, 6, 7% category where it's very difficult, less than 5, more than 5, or maybe more than 10, in that cases you surely may. But I believe I usually by the time, so honestly speaking, my team is I am proud of it, and my team is quite good in morphology. So quite a lot of times what we see on marrow very well correlates, if at all we are doing flows for a few patients. So usually that is not a problem. Also, if you do not have flow at your disposal, you do not have things, maybe a simple CD34 on bone marrow biopsy. So if you have IIC unit, you can do a CD34, and just a brief, just going through it, you can get to know if it is increased blast or not. But this problem usually occurs in cases of, the low blast category and not the frank blast. So I believe a CD34 would be much more resource useful if you want to go ahead rather than doing an upfront flow.
Thank you. Yes, Dr. Shweta, ma'am. Please
Yeah,
go
so can I come in, because we do
Yes.
it routinely, so I'll
Yeah.
just share our experience. So we don't rely on blast percentage on flow ever. We go based on morphology only, because the first pull for a diagnostic sample is always goes through the morphology. So once you are taking a sample for flow, it is always diluted compared to the what you have taken for morphology. So what we do is we always go for blast percentage based on morphology only, be it for MDS, be it for acute leukemias, be it for plasma cell disorders. We don't rely on percentage by flow, because of the fact that flow sample will be always diluted by peripheral blood.
Exactly. And I would want to agree with her on that, for especially for plasma cell neoplasms. It's quite a lot of times you see something else on morphology, and it's entirely different picture on flow. But yes, somebody, as I said, for maybe low blast category, I would not recommend it doing for the higher blast category, because you have already crossed that cutoff of 10. So now probably I believe there should not be a morphological dilemma if it is, low blast, or anything more than 10 and less than 20 is very easily enumerable on your differentials on morphology itself.
Thank you. Another similar question regarding high-risk CMML, where is excess blast. Is morphology better or flow better in case of CMML?
Yes, for cases of CMML, I would recommend going through a flow, because you would want to have a look at the monocytic, your myeloid, all the populations. For CMML, I would recommend going through a flow once.
Thank you. Yes, ma'am.
Yeah, I just wanted to say that morphology, yes, but very often you have a lot of dysbiosis, and your NGS report is going to come after 3 weeks. And at times, flow, as was told by the doctor from Tata Memorial, it's very, very important. We look at the Ogata score for diagnosis. We don't do the blast count on flow. you can look at the aberrancies on the blast on flow if it's an increased blast,
Yeah.
because it may help in the future, because those patients may progress to acute or may turn out to be acute myeloid leukemia if you get recurrent cytogenetics with even 10% blast. So a flow at the time of diagnosis of an MDS is a very good entity in low blast, looking at the dispoises by the Ogata scoring, and in increased blasts, looking at the blast aberrancies. And suddenly, when you get your report of your molecular and it turns out to be 821, you're going to call it 8, or a NPM1, you're going to call it an AML.
Exactly.
So it becomes very, very important. And a large proportion of AMLs, the blasts are CD34 negative. And if you have not done a flow in increased blasts and you are looking for CD34 positive blasts on bone marrow biopsy, you're going to give a false negative. So a flow cytometry in a number of cases of MDS is important at the time of diagnosis.
Exactly. Very well said by Madam. Whenever, exactly as I said, so for low blast, I would not recommend, but yes, for increased blast, whenever we are doing the more than 10 cutoff, the IB2 category.
No, even in low blast, to know whether it is dyspoisis, you are not getting the report of the chip of your clonal hematopoiesis early. To know whether the dyspoisis is secondary in India, very often you don't get the history of Ayurvedic drugs.
Yeah, that's true.
And flow and Ogata score helps. And as also was discussed in cases of CMML, yes, you have to do the monocyte subclassification at times. You do not know whether it's an MDS, MPN, or it's a CMML. And these things, flow does have a major role to play at diagnosis. Not only for increased blast, yes, to subclassify the blast, but also in low blast where the Ogata score becomes very, very important.
Absolutely, ma'am.
Sure. Great.
Fantastic, ma'am. Thank you for throwing light on this. And another question has been raised by Dr. Gopinathan. This is regarding MDS with fibrosis. In MDS with fibrosis, aspirate is always dilute, so the blast percentage will be compromised. How would you go ahead here in such cases?
So you can surely go ahead with the entire IHC panel on the bone marrow biopsy. I would rather suggest that is the most easiest way to go ahead with. Firstly, the lineage, the amount of blast that you have. So I believe an IHC would be an easier option to go ahead if you are having a immune-related smear and there's a lot of marrow fibrosis. So even for quite a lot of cases of leukemia, wherein the marrow is too packed and you cannot get any aspirate, IHC is the first step that we go ahead with in a resource poor setting.
Thank you. Jyoti ma'am, you wanted to comment something?
She said the right thing, that in fibrosis, but again, sometimes when you have just that, those 4 to 5% in the peripheral blood, you subclassify the blast, because again, you may not in all myeloid leukemias have CD34 positive blast. So then you may have to do a combination of CD34 and 117 IHC, along with the 71 to rule out the pro-erythroblast, to come to the exact blast burden on biopsies in these dry traps.
Exactly. The entire panel of leukemia, maybe, to go ahead with.
Thank you, ma'am. Another question from Dr. Gopinathan. What would be the best, bone marrow sample or peripheral blood sample for fish or molecular, for fish study or molecular study? So bone marrow sample is better, or a peripheral blood sample is better for any mutation analysis?
So I believe for cytogenetic analysis, always try to have a bone marrow sample. So it's quite tricky to maybe have enough phases on peripheral blood. So I would rather suggest for cytogenetics, you should always try to have a bone marrow aspirate sample.
Thank you. And what would be better, fish or molecular? And what is the difference between the two, pros and cons?
Again, I would rather say this in a resource poor setting. So for quite a lot of times, we go ahead with the fish first. If the patient does not have enough money for the entire NGS panel, so probably if resource poor setting, you can do a fish, and if you have, you can go ahead with both. Yeah.
Thank you. Another question from Dr. Yi Montent. What is the usefulness of circulating tumor as well as cell-free DNA at initial diagnosis or at MRD testing? Is it feasible clinically?
Great. Lovely question. So that's why I added into the category of newer modality of testing. So these are all maybe researched on, or maybe a lot of research is going on onto these topics. These are not used routinely as such to find the circulating tumor-free DNAs at initial diagnosis or MRD. You have better and more sensitive and specific testing for at the time of diagnosis to find out maybe the mutations that are there. But I believe these are not feasible clinically right now. But yes, a lot of work needs to be done on this. As we said, even flow for MRDs is not that advised. Maybe at diagnosis, but not for your MRDs as well. So MRD testing in MDS is quite evolving, and so is circulating cell-free DNA.
Thank you. Another question from Dr. Anju. What steps would you like to suggest for diagnosing the myelodysplastic neoplasms in resource-limited settings?
Okay, great, lovely question by Anju. And I believe the entire question answer session that we have been going through as to how we can go ahead in a resource poor setting. So for example, for a setting in mind, we are quite sure on morphology whenever we are seeing things, and then we go ahead with your diagnostic. So be it resource limited setting or a resource rich setting, you have to have your morphology very strong. You cannot, if you have resources, you just cannot put up the entire panel just because there are resources. And if there is resource limited, you cannot choose to put a few till you are not sure on morphology. So if it is a resource limited setting, you have and strongly have to be very strong on your morphology. You need to see the patient as a whole. It is not just morphology. It is not just peripheral blast. It is not just marrow blast. It is not just dysplasia. So it is an entire, maybe a clinical presentation of that patient, maybe any nutritional defects or autoimmune, as we discuss, any drugs, any, like Jyoti madam said, Ayurvedic medicines, or maybe previous malignancies, so things like that. So whenever, honestly speaking, when we go for a marrow procedure, the entire history is taken by my team. Right, again, whenever we go, we ask for all of these things. So we have a lot of background history at hand before we are seeing the slides to avoid the kind of bias when we see the slides per se. So resource limited setting, yes, morphology to begin with. Morphological clues to predict the molecular markers that could be. And to begin with, maybe I believe flow, if that is available to you, if not, a fish minimum, at least a fish for MDS panel has to be done to maybe establish and maybe help the clinician to go ahead. And NGS, if you can, that is a cherry on top.
Thank you. The question is, if an elderly person comes with unexplained anemia and the bone marrow shows just erythroid hyperplasia with megakaryocytes showing just separated nuclear lobes in the megakaryocytes, and cytogenetics is absolutely normal, molecular studies are normal, should we classify this as MDS refractory anemia?
Oh, lovely question. So to begin with, I would want to know what is the percentage of dysplasia to begin with. It has to cut off more than 10%. And in elderly, as we already discussed, clonal hematopoiesis, it is seen in aging population. It is very commonly seen. So an incidental, so for example, the association with cardiovascular disorders was picked up on the basis that this is seen in the aging populations. So probably you may have a clonal hematopoietic mutational pool in these patients. But yes, for this case, I would want to know the dysplastic features, the cutoff, if it is more than 10%. And along with that, what kind of dysplastic features we are seeing. If it's just maybe some cytoplasmic blebs or maybe just cytoplasmic maculations, I would not be too keen on labeling it as dysplasia. So dysplastic features, they are quite, I would rather say quite lineage specific. So I would want to know what kind of dysplasia he or she is seeing. And probably these cases, maybe I would want to go ahead with caution, because there are chances. I'm surprised because even if you are seeing dysplasia, you're not seeing any clonal hematopoietic markers as well on the NGS. So NGS is negative. If with this kind of background, your molecular markers negative, I would want the diagnostician to revise the clinical history once to see if there are any confounding factors which are causing this kind of dysplasia, which is causing these kind of cytopenias, if there is any autoimmune or maybe viral or maybe drug associated or maybe some association which is causing cytopenias in the periphery. And along with that, I would want to know the cellularity of the marrow to begin with. So an elderly, 70, I would want to know what percentage of cellularity is there in the marrow. And along with that, what percentage of dysplasia we are seeing.
Thank you. But the question is, the patient has come to with just anemia. WBC is absolutely normal. Platelet count is absolutely normal. There is just erythroid hyperplasia, but display is just limited to megakaryocyte lineages, which is more than 10%. Should we call it as MDS?
I would want to label this with caution again. So even if it is more than 10%, I would want to label this patient with caution. I would want to go ahead with NGS. If NGS is negative, I would want to revise the patient. I would want to go through ahead if there are any other factors. I would want to see if there are any chronic diseases that are there in the patient, if the patient has any cardiovascular disorders or maybe any renal disorders. So I would want to rule out that background of chronic inflammation, which may be causing these cytopenias and this dysplasia.
Thank you. Another question which has just come up. In case of MDSs, which genetic mutations just suggest that it is insignificant if you are getting on molecular?
So if I get the question correctly,
in case of MDS, already proven MDS, and the testing shows some mutations which has been prominent on NGS. Which are those mutations which we should not consider as significant?
Okay, so great question. So I believe diagnosis of MDS has been made on the basis of morphology, and we have a NGS report as well. So as we said, as I said, CCUS is the father and VAF is the mother of MDS. So I would want to know what is the VAF for all of these mutations that we are talking about. And only after that, the clinical significance, if they are significant or not, could be decided on that.
Yeah, because what he wants to know is that whether in case of chip mutations, like we have got DNMT3A,
Yes.
ASXL1, which is very common.
Yes.
Can we, if we're getting those mutations, should we label it as MDS? Or just we can call it?
Can, but if they have a cutoff of VAF of more than 20, only then. So all of these, only then you can put these. In fact, all of these markers are predictors of poor adverse prognosis, right? So DNMT3A, TET2, all of these are, as we discussed on the slide, that it showed a favorable and an intermediate and an adverse prognosis. So these are adverse prognostic factors. So I would not consider them as the minor markers as said. So if you are seeing DNMT3A VAF more than the cutoff of 20, that's fine. It's already MDS then, with a very poor prognosis. Rather, in this case, I would want to have a look at the blast. Chances are the blast may be nearing around 20, or they may have crossed 20. If it is an elderly, if it may have crossed more than 20, we are looking at directly an AM LMRC now.
Thank you. Another question from Dr. Shyam. A patient with refractory anemia with TET2 mutation on NGS, can we label it as MDS?
Refractory anemia. Age, I would want to know about this patient.
So age he is not mentioned.
Okay.
Mutation, refractory anemia on NGS and TET2 mutation, can we call it as MDS?
Okay. Again, I believe if it satisfies the cutoff of VAF, we surely can. Not an issue.
Great. Another question from Dr. Anju. What type of erythropoietic reaction you find in cases of MDS 5q deletion? Is it megaloblastic or normoblastic?
What type of erythropoietic reaction you found in cases of MDS 5q?
Yeah,
Is
is it megaloblastic?
So yeah, as we discussed, you see a lot of macrocytosis, you see a lot of erythroid, a lot of early erythroids in the background in MDS 5q. But I would rather say if you have a diagnosis of MDS 5q, I would want the diagnostician to have a look at the MEGs first, because that would be much more, presenting with dysplastic features. But yes, it could be a megaloblastic or normoblastic, both. So it's not too specific. So erythroid presentation, dysplastic presentation is not too specific for 5q deletions.
So macrocytic picture on peripheral blood
It
smear.
could be found, yeah. Rather, I believe the first clue for me, maybe whenever I'm seeing somebody more than 50, 55, refractory anemias, the first thing I want to see is the MCV. The first thing I want to know is the history of hematinics. And the first thing I want to know is the LDH levels. So which maybe supports in what direction maybe I should be seeing. So yes, macrocytosis is very commonly seen in cases of MDS with a normal LDH and no history of maybe repeated transfusion, repeated hematinics.
Thank you. Another question from Dr. Gopinathan. 72 years male, isolated macrocytic anemia. B12 is normal, non-alcoholic, history of myasthenia gravis, on Azuran, DCT negative. Peripheral smear shows macrocytes, anisocytosis, and even after nutritional optimization with Azuran, how common is to have this isolated macrocytosis?
Okay, lovely question. So there's one entity, I don't know if this case fits into that, folic acid responsive macrocytic anemias. So I believe this case could be that, but yes, considering a 72, I'm not wrong if the age is 72, right? But
It is
with
7.
this elderly, I would want to explore for MDS first rather than thinking of the rarer possibilities later on.
Thank you. Another question from this patient had a retic count of just 0.9%. Okay.
Okay.
Another question from Dr. Jyoti Saune. In cases of MDS with ring sideroblast, after treatment, do the percentage of ring sideroblast go down on the bone marrow aspirate?
Oh, lovely question. Uh, I never thought on these lines as to what happens with the ring sideroblast, but with my understanding, probably when you start therapy, so there's a lot of destruction of your clonal population, which is there. So it should go down, I believe. We have never maybe done a repeat ring sideroblast post-treatment, honestly speaking. And honestly speaking, ring sideroblast, we've not seen that commonly. So till now, we've seen just 2 cases of ring sideroblasts who are SF3B1 positive. And honestly, we did not do a repeat marrow to see like how the ring sideroblasts go down after treatment.
Okay, thank you.
Yeah, they do go down. We've had 4 or 5 cases which we've followed up,
Lovely.
and they do go down because once there's that hematological remission, and if sometimes to decide on a transplant or some other issue, a marrow is done, and looking at the remission status, yes, they do go down.
Go down, yeah. So because we are hitting the clonal population, so they
Yeah.
have to go down, yeah.
Thank you. I just want to add on this thing. In case of refractory anemic ring sideroblast with SF3B1 mutation, we have now a very new drug which has come up, that is luspatercept.
Yes.
I think with the treatment of luspatercept, this is feasible because it may act on this level also, that the RS level, that ring sideroblast level may go down. Exactly the same phenomenon, because I don't think so whether if you're just putting the patient on erythropoietin in case of RARS, whether
Yes.
this thing happens or not. I don't know that. Well,
Yeah, I believe for MDS, the star drugs have been venetoclax and luspatercept, the talk of the town, and quite a lot of clinicians are quite happy with the responses these drugs have. So lovely input from sir.
thank you. So anybody else has any other question? Well, so there are no more raising signs, and there are no more questions from the audience. Well, thank you so much, Dr. Neha, for that wonderful insight into the MDS. The journey of MDS on morphology was so fantastic and very well narrated, and your presentation was wonderful. And thank you for all the question answers we had over here. And I also request, one more question has just come up.
Okay.
Dr. Oh, okay, we'll take up this question from Dr. Bhuvesh Varnath, Gauri.
Yeah. Mm-hmm.
Elderly admitted patients with acute infection as trainee screening blood films. Sometimes we see occasional peripheral blood blast with a dip in the remaining counts. This can be an underlying MDS. Adding guidance as to what would be done, the appropriate timing of doing a bone marrow in this setting. Because if done too early, could we wrongly upstage it to from a CCUS or MDS with low blast to IB1 or IB2 with infection, destroying the whole blood picture or a bone marrow picture. So can you please advise or comment on this?
Okay. So I'm sorry if I must have missed the age. What was the age for
Elderly.
Elderly, okay. Elderly with infection, it's very quite commonly seen. As I said, MDS background has always been chronic inflammatory background, and chronic inflammatory disorders quite commonly seen. A lot of them have cardiovascular, quite a lot of opportunistic infections being elderly. So for this case, I would want to maybe, so the marrow findings are for this case, we are seeing, or it's just the peripheral smear finding?
So peripheral smear shows cytopenia with occasional peripheral blood blast count in case of acute setting of infection.
Okay. Okay.
So
Okay. Great.
bone marrow, this can be underlying MDS also. We don't know what it is
Yes.
actually.
Yes.
So if we do a bone marrow at this stage, we
Mm-hmm.
can only upstage it from CCUS to MDS to low blast count to IB1, IB2 with infection, distorting the whole blood picture in the bone marrow picture. So
Yes.
when the exact timing of doing the bone marrow in such setting in case of acute infections in elderly?
So honestly speaking, if we are looking at an acute infection per se, a patient of sepsis, I would rather say the priority would be to take care of the sepsis first, because if we are doing it in an active inflammation, probably you are seeing a lot of myeloid precursors in the marrow, probably you are seeing a lot of reactive changes in the marrow. So I believe if possible, if the sepsis or maybe the infection part can be taken care of once the patient is stable, after that, probably if the counts have come up, maybe follow through the patient for the next 1 or 2 days if you are seeing similar kind of picture, or even after the sepsis or infection has been taken care of. Even if you're seeing persistent blast population, occasional blast population, yes, a marrow can surely be done. But yes, if there is a history of sepsis, I would rather want to take care of the sepsis. I would rather want to rule out HLH also for this case. So HLH would be a much more a priority rather than doing a marrow and then maybe working on that. So if we can take care of the sepsis and the infection first, at the same time follow through over the next few days what the trend of the cytopenias, what the trend in fact of the blast population is also along with the control of sepsis, and then maybe take an informed decision on doing a marrow. But yes, I would want to do a marrow, because you need to be sure if you were seeing those maybe a few blast cells or maybe a few large cells, were they because of the background inflammation or sepsis or maybe HLH, or maybe there's the marrow is throwing out because there is peripheral sepsis. So I would want to rule out. It would be a wise decision to maybe rule it out doing a marrow, but maybe taking care of the sepsis first. And then probably the marrow would be a better indicator once the sepsis is taken care of.
Exactly. Thank you so much.
Okay.
Knowledge you have. Wonderful discussion as well as wonderful lecture, as I already said. Thank you
Thank
so
you.
much. And I thank all the discussants and audience. And I would love you to participate again for the next week. Next Saturday, Sunday, again meeting you up at 7 p.m. Indian Standard Time, Saturday, at 11:30 a.m. morning, Sunday. Thank you so much once again. Thanks to all of you. Have a good
Thank you to all the participants. And I got to know a lot of things. Lovely discussing with the lovely moderators, and it was a great time. I'm really glad so many questions came up. I too racked my brains a lot. So I'm really glad it was quite an interactive session, and I thank all the participants for their queries. And thank you so much for moderating it so well for us.
Thank you. Thanks a lot.
Thank you.
Goodbye.
Have a great weekend. Thank you. Thank you so much.